So we said we'll push that ahead, we'll have the panel discussion now. And in the panel discussion, if you have any questions to the first two speakers or any issues regarding this, also regarding candidacy, you can please direct them. I think on the panel we'll have Dr. Oza. Oza sir? Dr. Mallikarjun from Ahmedabad, who's running a very successful cochlear implant program. He and his wife form a team for audiology and therapy. And Aziza from Orange, who has the largest number of our cochlear implant children at the center. And microphone take mobile.
This is regarding what Anuradha.
You have to identify yourself and then go to the question.
I'm Zui Khokar. I'm a special educator running a center in Navi Mumbai. And I would like to ask about what are the ways to diagnose the problems related with auditory cortex?
Anuradha, you can answer from there.
Unfortunately, as you go higher up in the auditory system, the problems get more and more subtle. So the child or adult having a problem related to the auditory cortex would be able to do most of the simple tasks. Like if you do word recognition, for example, you may get 100% word recognition score. It's very important to use those kinds of tests or test material which would be able to tap problems of that area. Like for example, if you are doing very complicated messages, like you are giving different signals to both ears at the same time, which are called dichotic signals, or you are putting something like time compressed speech, like you are interfering with the time related patterns of speech and giving that kind of a signal and asking the person to identify what you said. There are all these kinds of fancy, if I may say so, material which you have to use if you want to detect a central auditory disorder. So there is something called the subtlety principle. That means that as the lesion goes further away, higher and higher from the cochlea, its effects on day-to-day auditory functioning are more and more subtle and difficult to demonstrate on different tests. So in India, we have very few tests which can really tell us about central disorders. Because you have to have language-specific tests, you also have to have recorded. There are quite a few tests. And it's not always that non-speech tests would be able to tell you about these functions. So it is an issue in India that we need far more tests than what we have already. But if you look abroad, there are lots of different kinds of tests which you can use, and they're quite specialized. They're not the usual tests that we talk about in audiology.
Thank you, Anuradha. Any other questions? Questions to Rajesh regarding the implant itself? Has anybody got questions for him? Okay. Dr. Oza, since Nishita is not well and the next lecture was on candidacy, would you give us a few guidelines as to how you decide whether a particular child, we're talking about prelinguals now, is suitable? Very broad guidelines, we'll go into the details later. As a candidate, who would you consider a candidate to be cochlear implant?
I think first of all it's very important that all these children have gone through the complete battery of tests in audiometric evaluation. Most of the time, unfortunately, the cases are just thought of in terms of deafness because BERA is not strictly verified. I do insist that right from free feed onwards, including BERA, ASSR, all these tests should be done, and when the child fails those tests, ideally one would consider such a case for cochlear implant. But that is also not feasible if we are not able to detect any other underlying neurological problem which is likely to affect the outcome of the implant. And therefore it is necessary that it's not just an audiological diagnosis, but also neuropediatric evaluation becomes a necessity. With these two things, if everything is in favor of the implant, and then if the ENT surgeon also agrees. Third thing is the CT and MRI, which should show whether the cochlea is intact. If cochlea is intact, whether the nerve bundle is also there or how well developed it is. In case it's an absent, or even in case where the cochlear malformation is there. Again, it is the ENT who is going to finally decide. And now that you have got these special electrodes available, even for these cases where there is cochlear malformation, it becomes easier.
Okay. Dr. Mallikarjun, could you give us any comment on age and your decision making as far as the age is concerned?
Well, having been working in cochlear implants since last 4 years, now we have also come across, we were under the impression that children above 9 years may not be, or 7 years may not be a good client. After giving a trial and having tried with a couple of adolescents and adults, and the progress that we have seen, now I think that age may not be a criteria as long as we give an auditory sensation and perception is concerned. The child, adolescent girl about 18 years old whom we implanted a couple of years ago, she is doing excellent. After seeing the result, I feel that we should consider even the late age group also. Only thing is we should give very intensive, we have to do an intensive work with them. If we give that, the sensory deprivation these children had, or even this adolescent had, that can be reversed and the sensation can be given. Outcome probably may not be as good as we see in young age children, but outcome is really favorable and encouraging, at least in our situation here.
Yeah.
In this older age group, when we are discussing what older implantee, when you are planning to implant an older person, you have to remember that 1-2 things, whether they've been using hearing aids consistently or not. If they're using hearing aids consistently, at least may not be effective, what auditory sensations are going, at least something is there, better than nothing. So they should not be absolutely, people we get, even 6-year-old no hearing aid usage, I'm sure may not do that well than a 6-year-old who uses hearing aid. The same thing as Dr. Mallikarjun said, that older people, if they're consistently using hearing aid and has developed spoken language, are the one, you could go ahead and advise cochlear implant. But you have to remember, give them the proper expectations and things like that. They should understand what we are looking. We have to tell them that what we are expecting. Mainly when we are implanting older people, it is the environmental sound, ear to lip reading, and the speech may not improve drastically. So that has to be understood by the family, and once that happens, we can go ahead. Otherwise, they feel cheated, that you have done, and then so and so 18-year-old is doing well, and my child is not doing so well. So that really needs to do.
Dr. Oza, you wanted to add something.
I'm not going to talk about 9 years and 10 years, but about 25 years and how one of the adult persons, one of the adult girls, who had profound hearing loss, who had come up from early childhood with only pocket hearing aid, but father was a lecturer, and how much he worked in Bihar. She had developed typical speech that we see in hearing impaired. And at the age of 21, we gave her digital hearing aid, thinking that she can improve. She did improve her in speech. And then, after using those hearing aids for 3 years, we considered whether she could go for cochlear implants. She went for a cochlear implant. All her high frequency sounds, became not only clear, but she is today working as one of the middle grade executives in the HDFC. She calls up regularly. She got married, and if you listen to her speech on phone, you won't believe she had so much of hearing loss. What is important therefore is that the appropriate use of hearing aid and training, auditory training, followed by proper speech work is the ideal thing. And I think she is one of the ideal cases, for encouraging similar cases, not any hearing impaired above 25 who has not used hearing aids,
Aziz, I have one question for you. It's now said that ideal age for implantation in children should be between 1 and 2 years of age. That would be the ideal age to catch them into an implant, because you would get a better result rather than if you do it at between 3 and 4. And then if you did it at later ages, the results may not be as good. Since you have such a large number of children with you, what's your take on this?
Yes, definitely it is. If a child is done at the age of 1 and 2, you get excellent results. But if at that age they are also fitted with correct hearing aids, and when I say correct hearing aids, I really mean not prescribed hearing aids, because that is what a lot of audiologists are doing. The minute they see on the audiogram that a child has a profound loss, they write a prescription and they go and buy the hearing aids and wear them. And I know a lot of people who do this. So if proper hearing aid trials are done and they're fitted with good hearing aids, if a cochlear implant is not affordable, that child can develop very good speech and language to start with. And a cochlear implant can be considered later. I know that we have a large group, we're talking about late implantees. There were about 6 children who were implanted at 6, 7, 8 and 9. But they've been with us from the age of 1. And they had very good language, good speech. The speech that was not correct was in the frequencies they could not hear through hearing aids. So the minute they got their cochlear implants, all that with a lot of self-correction and habilitation, they were able to do very well. So a young baby, if it goes in for a cochlear implant, nothing like it, because you just have to not teach it, but treat it as a normal hearing child, and develops very well.
Okay. Rajesh, thank you. Yeah.
When it comes to best hearing aids, people think digital hearing aids are best hearing aids. So that should not be the situation. They may be best for the people who got good residual hearing, from mild to moderate and moderately severe type of hearing losses, but they are not really for those who are profoundly deaf. So best hearing aid does not mean digital hearing aid. The hearing aid has to be fitted appropriately. Whether it is analog or digital or programmable, it does not make any difference. What we, as surely what we are looking at, we should be achieving it.
So I think the message coming through is early detection, early intervention is what we're talking about, whether it's hearing aids or cochlear implants. And that's something which all of us have to think about. I think as a group we failed miserably in promoting early detection. We haven't been able to convince the correct people that we have to do this. And there are so many countries where neonatal screening is compulsory. And we have people with us here who are willing to do it, but for some strange reason, the various specialists concerned, the pediatricians, the obstetricians, and even the hospital administrators are still having some kind of a block, which is something that we have to knock and break down. Another one question for you. There's a lot of talk about preserving hearing when you do a cochlear implant. Believe me, it's not always easy because it's not in your control. When you put that thing inside, I mean, you're sweating as it is to get the thing in, and then you want to get it in without damaging anything. And I was at a conference when somebody said, it all depends upon exactly in which direction you point the implant when you put it. I said, what 1 millimeter hole there, and you're putting an implant, and then you want to choose the direction in which to put it in. So, people are talking about the auditory and the acoustic and electric.
And obviously, our brain is able to put those two together, where the fact that we can listen in such adverse listening conditions where the noise signal is probably less than a noise, it's reverberant, and so much of acoustic insult to our brain, if I may say so. But we are able to understand speech through all of that. So obviously our brain is very adaptable and we can take a lot. So it works well.
To me it's very surprising, because if you talk to a post-lingual patient, I mean, I had the occasion to do that, and after an implant I asked him, what does the speech sound like compared to what you used to hear before? This fellow became deaf after he had a motorcycle accident and meningitis and things like that. And he said it sounds like robotic speech. The frequency modulation is not so much, it's more monotonous. So I'm wondering that when I say something, maybe the implant is giving a slightly different frequency response as compared to what the acoustic response is giving. So he's receiving the same sound at two different frequency levels at the same time. And yet we find, and especially children, they are much better off using a hearing aid on one side and the cochlear implant on the other. I think the adults also do that, but they tend to take a little longer perhaps, a little longer.
They take longer, they do, and some of them will tell you that I need the cochlear implant to be listening to very soft sounds, but I need my hearing aid to understand speech. So they use these two things together, and it seems to work complementarily rather than against each other.
And this is the reason why there is a lot of research going on now. I think one of the companies, I think Medel, has already a duet which takes care of the high frequencies with the electrical stimulation and the low frequencies with the hearing aid. The nucleus is working on what they call the hybrid, which is going on. So it's all moving towards trying to preserve what is already there. And Rajesh, talking about this hybrid, etc., are there any other newer developments in cochlear implants that you would like to tell us about? Where the research is going on towards what?
No, I think this is what, as just to say about the damage which is caused by the implantation. First of all, we have to understand that we are implanting, the usual implant, person who is undergoing cochlear implant are the one who's got profound hearing loss, who is not getting benefit with hearing aid, because Nishita would have shown her in a slide, and then they are a candidate for cochlear implantation. They are not getting enough experience, benefit from hearing aids, so we are doing cochlear implantation. So I really am not too much worried about losing hearing aids.
No, I'm talking about what is the new research being directed towards in cochlear implants. What further finesse are they adding to cochlear implants?
They are just getting new strategies which works. After all, as I said in here, profound hearing loss. It is difficult to hear in noise. The music, the telephone conversation is all a problem, and then especially the tonal languages. The people who we also have tonal languages and other languages. They are working on those aspects where they can make strategy on such implant which gives better performance, still better performance in noise, music perception, and the tonal language perception. And the other thing is, as usually whenever there is a lot of high frequency hearing loss, what audiologists would try to do is they would boost up the high frequency information. But there's a study which shows that when 3 kilohertz onwards, if the threshold is 55 and above, no matter how much high frequency boost you give, the person is not going to get, they may get access to speech. You may show the threshold in the speech spectrum, but in reality is not getting so. So in those situations, the hybrid implant or a duet, where electro-acoustic combination works.
Any mention about the tiki?
Yeah, they have.
Tiki is a totally implantable cochlear implant with nothing outside.
Yes. They already developed. I think field trials are on. There are some patients and the results are encouraging. Only there are a couple of problems regarding the microphone and the battery. I'm sure they will be able to overcome that problem.
Dr. Oza, coming back to you, as far as the post-lingual group is concerned, which are the people who you would say would be good candidates, and where would you say, in spite of a post-lingual deafness, there is no point in operating?
First of all, I would say that most of the post-lingual cases have excellent language and speech, and therefore, theoretically, they are really good cases or favorable cases. Even these adult cases, post-lingual cases, even after the implants, need initially good intensive training, and without that they also have problems in accepting the new quality of sound that they are hearing. We had, and I think if you remember Mr. Shaila's case, which is a very good case, who lost hearing suddenly overnight with very severe viral infection bilaterally, total loss. No hearing aid would help. Even the one of those atom bombs which was burst as 2 feet could not create any reaction in him. 4 years later, he was implanted with 16 electrode Murali implant. In 3 months' time, he became practically normal in terms of his day-to-day function, got back to his work. Today it's more than 2 years now, and in spite of 16 electrodes, he says, I can now understand music, I can predict which song is going to come up. Now this is again a classical example of how
my question was more towards.
But now in terms of selection of cases, I think basically I would certainly recommend those cases who are not really going to benefit with the hearing aid. Second thing, they have to accept it. Third problem, and this is important when it comes to India, is that they should be able to maintain their implant after surgery, because maintenance cost varies from implant to implant, and not many of them can afford monthly expenditure, maybe 1,000, 1,200, 15, depends on what particular.
Do you think the duration of deafness plays a role in this?
Well,
if there is a 50-year-old man, if there is a 50-year-old man who became deaf when he was 10 years old, and he now heard about an implant and came. So I'm just wanting to say, where would you say?
I think earlier we implant them after the hearing loss, better it is, because speech regression has not occurred. And they can utilize much better the auditory memory that is still.
But is there any cutoff point beyond which you would say it's not much point?
Yes and no. Again, it depends. Where
give us the no part first.
No part is the one where there is very poor speech and poor acceptance of any amplifying device. And also there isn't proper family support. This is very important. But yes, if there is good motivation, good family support, even later cases also can be taken and they could still do pretty well.
So the reason why I asked you this is because there was one very high profile patient who was implanted, I think 60 years after he became deaf. And when he came back, he made a very profound statement to the press saying, I can hear the waves of the ocean now. What he didn't tell us was that was the only sound he heard. And then he had to be explanted.
And then he went on of getting more and more other implants. I understand now he has gone for one more implant after 2 previous ones he had appreciated.
The same patient, what we are talking is, when we evaluated the patient, we had already told, because that was high, as you said, it was a high profile and a double-edged sword on my head, especially to implant him or not to implant. We have given facts. What you really need to be giving is facts.
But you made a smart decision. You sent him to Australia, Rajesh.
Oh yes. Other thing is coming to your question of what and duration. Duration always matters. Early is better, but what really matters is how much do they remember. The auditory memory is really very important. As a person who loses hearing, at a younger age, but still remembers, may do well. But so here again, when you have a long-standing, hearing loss, you need to counsel them. You need to tell them. It all depends upon how much your brain knows and identifies and would then correlate with the new sound which is coming. So person still has auditory memory intact. Maybe even there will be 50 years of. Being a 30-year-old, there's a duration which was 30 years of deafness, profound deafness. But that lady has got now 80% open set. She can talk on telephone.
And there is no upper age limit. The oldest we've operated, I think, is 78.
78, yes.
And I've got an 85-year-old German lady waiting to be implanted. She says, first let me have my kidney replaced. Then I'll come for the cochlear implant.
So in keeping with the neurophysiology and thing, there have been some studies which show that interestingly, when you talk of auditory deprivation and loss of spiral ganglion, so when there is a period of deafness, the spiral ganglion seem to atrophy, and we know that. But the funny part is that if the cochlear nucleus and higher centers have got stimulation at some point of time before, they don't regress or they don't atrophy. So that could be a reason why people who have had prolonged periods of deafness but have earlier been hearing, so you know that that deprivation doesn't occur. So if you find that not much of atrophy has occurred at the lower level, at the nerve level or the spiral ganglion, probably those are the cases that still do well.
So how would you confirm that?
So I don't
would
know.
Would a Bromonti stimulation test be of any value?
Probably something that would tell us about the spiral ganglions and auditory nerve would probably
So if
be
you
a
have a
form.
prolonged, would you say that if you had a prolonged period, you would do a promontory stimulation to see whether it might be worthwhile implanting?
Yes, I can't say for sure. I don't have enough information to say whether that would give us the 100% this. But I remember at one of the CDs where I don't know, I don't remember exactly who presented, but it was I think Saji who spoke that they expected that to be not the right year because it was the person chose to go in for implanting the ear which had had a longer period of deafness than the better ear, and they thought he's not going to do very well because it's the side which is unused, and he did quite fine. And I think this could be explaining why, because you don't have deprivation occurring above
I think we'll have to call a halt here, and I'm sure there are a lot of questions in your minds which you have not still brought out. Please make a note of it, and as I said, the whole idea is to answer your questions here, so please feel free to ask. Even if you feel that a question may sound a little silly or stupid, doesn't matter, just go ahead and ask. And it's better to clarify your doubts here than keep on wondering after you go back, why didn't I ask that question? Thank you very much to the panelists. We break for coffee now, and in about 15 minutes.
Can I interrupt?